Dr. Garcia at this point.
Thank you, Dr. Cullen. This is the first meeting of the Back to Business Task Force Road to Recovery subgroup on May 7th, 2020 at 9 o'clock in the morning here physically in the Board of Supervisors hearing room. I'm going to take the roll call, starting with our chair, Dr. Cullen.
Here.
Our co-chair, Dr. Nancy Johnson. Nancy, are you here?
I am here. Do you have me muted?
Thank you, Nancy. I'm sorry about that. Dr. Michael Abekasis.
Here.
Dr. Iman Hakim.
I'm here.
Dr. Clint Kuntz.
Yes, I'm here.
Dr. Jonathan Leonard.
Does not have a mic. I can chat and then ask him.
Okay. Ms. Rose Lopez. Rose, are you with us?
Yes, I'm here.
Oh, thank you, Rose. Ms. Judy Rich.
There are two callers. I can unmute both and you can find out which one.
Sure.
I'm here.
Thank you, Judy. Mr. James Stover. James, are you with us?
Here, yeah, can you hear me? I'm
Yes.
here.
Thank you, James. Appreciate it. And Dr. Chad Whelan.
Yep, I'm here.
Dr. Whelan's in the room here with us. Staffing this committee is myself and Dana Morales. Thank you all for gathering here. I will remind you, because this meeting is being transmitted, to please, as you make your comments, to please re-identify yourselves, get close to the microphone, and then proceed to make your comments. I'm going to turn the next agenda item over to our administrator, Mr. Chuck Huckleberry, who will give it the charge for the task force.
Thank you, Dr. Garcia. And I'm going to be very brief because I think when we basically conceived this Back to Business Task Force, it was with the idea of getting community input from all sectors regarding how we actually recover from a post-COVID-19 concept. That is one that I think when we entitled this particular group the Road to Recovery, it's all about basically listening to the science and the medical professionals and the public health professionals that will guide us through this process to say, here are the things that you can do, when you should do them, and here's how best to basically protect the public with regard to the COVID-19 infection. And so I think our, the purpose of your group is to give us that advice, and so that we basically take the position, and the county will take the position, and already has taken the position, that we will reopen, and all of our activities in reopening will be guided by the best possible public health science. So that's really what we're interested in, and we think that this particular group is best positioned to give us that advice. Thank you.
Thank you, Mr. Huckleberry. Any questions or comments about the charge or clarifications? Terrific. So I'm going to move us to the next agenda item, which really is just briefly kind of recapping what the actions of the executive branch have been in terms of the response to the COVID crisis. And specifically, there are things that we can and can't do. There are things that are not in our control that are, the province of the chief executive of the state. And I think that any actions that we take ultimately sort of have to fall in line with that ethos. So I'll just remind you that on March 11th, Governor Ducey issued a declaration of public health emergency in response to what was then the first confirmed case of COVID-19 in what ended up being a Pinal County case. Shortly thereafter, a raft of executive orders were issued, the first also on 3/11, describing protective measures against COVID-19. But really the biggest and most important executive order came on 3/30/2020, and that was the stay home, stay healthy, stay connected, physical distancing to mitigate COVID-19 transmission is how the executive order was entitled. And essentially that is the order that asked people to stay home, that really sort of shut down much of the non-essential components of commerce in the state, and that really encouraged social distancing and facilitated the mitigation efforts that were ongoing throughout. One of the things that has occurred since that time is that the stay-at-home, stay healthy, and stay connected order has been amended as of 4/29/20, which started to open up some retail activity. And then most recently on 5/4/20, the executive order called resuming additional business operations for barbers, cosmetologists, and dine-in restaurants. Effectively, this Friday opens up barbershops and salons and other sort of personal services, and on Monday opens up limited dine-in restaurants. The executive orders, by their nature, are relatively nonspecific and provide a template for what we should be doing, but fail to provide the details and the specificity that our operators need to be able to execute them. And for that reason, the county administrator has developed a variety of task forces which are designed to get the feedback of operators and the community as to how to interpret and how to operationalize some of these executive orders. As Mr. Huckleberry said, the task of this group then is to look at what we know about the pandemic in this community, and to think about what kinds of metrics we can use and are available in a public-facing way in order to provide the confidence necessary for our community as we move forward. Obviously, at some point, we will be opening up we will continue to open up the economic and social activity of Pima County, but being able to tie that back to some sort of metrics that are based on public health science and medicine, I think are really incredibly important. And for that reason, we have assembled a group of experts both in public health and medicine and community health to really sort of inform the discussion. So I'm going to stop my comments there, and I will take comments and questions before turning the presentation over to Dr. England. Any comments or questions? Anybody online? Terrific. Then what we will do is I will turn it over to Dr. Bob England, who is our Director of the Department of Health, who will provide a situational update of the COVID-19 response in Pima County. Bob and I started stressing about this actually back on January 3rd was the first time I remember talking to him about this issue, and it seems like now like years ago, and unfortunately, our anxieties were proven correct. We knew that we were headed into gem show season, and we were scratching our heads about what to do. So, Bob, I'm going to turn it over to you.
Thanks, Dr. Garcia. So it may not have been years ago, but it's taken years off my life, I'll tell you. We've been lead agency in the response here since January, began our formal response in January, have been ensconced in the Emergency Operations Center for almost 2 months now. Mostly responding by attempting to support our partners as best as we can, both logistically in terms of supplies and with information in terms of guidelines that seem to change every day. We have, I think, done a pretty good job with our website of pushing information out, and have focused our assistance on those parts of our community that we identified early on as needing the most help, especially long-term care facilities. We knew right from the beginning that they were a setup for sustained transmission and transmission to those most at risk, and in fact that has proven to be the case. More than a fourth of all of our cases are associated with long-term care. More than 40% of all our hospitalizations and more than half of our deaths. So they continue to be the focus of our efforts going forward, and we'll talk a little bit more about that as we go along. So as Dr. Garcia takes over here and talks about geographic distribution of cases, I want to emphasize that a lot of that is driven by locations for long-term care. And that's why we moved away from looking at zip codes per se, because a single facility outbreak and a single zip code drove the numbers there.
Thank you, Dr. England. One of the big issues that has emerged as we've been dealing with the pandemic has to do with the distribution of these infections throughout our community. Very early on, as we dealt with the first few cases, it was clear that the first 11 or so were travel related. They all seemed to have some sort of linkage to travel, either cruise ships or East Asia. But soon thereafter, we started to notice that we were seeing evidence of community transmission. And at that point, we moved into mitigation mode, and because you couldn't contain it, once it was in the community, you had to assume that it was more widespread than you were seeing. That and the fact that testing was very, very limited and was really being used only in the most severe hospitalized cases. I'm gonna play an animation for you that has been developed jointly by our GIS and EPI teams that I think is really important because it shows how these cases have played out in this community. And Dusty, I'm good to go? Okay. And terrific. Thank you, Dusty. So this is an animation of the cases as they have played out in Pima County. And the cases will appear as bright red dots. The cases will stick around for 14 days, which is the typical period of infectivity. Please note that the cases are mapped based on the date that the specimen was collected, because we have no real way of understanding when somebody first became symptomatic. So with its limitations, we share this map with you because we believe that it helps us contextualize the risk for our community. What you start to see is you get sporadic cases. It actually started down here in Green Valley. But you'll also start seeing cases age out or as the period of infectivity wanes. And like I said, it was fairly clear to Bob and myself after about the second week that we were clearly in a community transmission mode where we were seeing cases pop up that had no possible epidemiologic linkage to anything else. So I'll share with you also another sort of representation. So what the state has done has really largely relied on presenting zip code coded data. And the zip code data has its strengths in that people recognize zip codes, people identify with specific zip codes, but the zip code data is limited because zip codes can be geographically very different sizes and have very, very different populations, and there's no real way of kind of standardizing that. And so what this map tries to do is it takes the population of the zip code as the denominator and the number of cases as the numerator, and this is a cumulative map of the cases by zip code. And you know, as the color gets hotter, redder or browner, you have more cases. And what you just is obvious and evident from this is that we are living in the midst of a sea of red and brown, and that's what this map is meant to convey. The story is actually a lot more subtle. This is the number of cases in the numerator and the population on a per census tract basis. And what I want you to see here is that our cases really have been driven by just a couple of census tracts which have experienced lots of cases. Again, down in the Green Valley area, also Midtown near our Banner South campus, and increasingly up and down the I-10 corridor and the Rita River, where we have some fairly large retirement-related and assisted living and skilled nursing facilities. That's where those bright red census tracts are, and I think that is a point worth mentioning. That's also been the justification for why Bob has dedicated so many resources to our long-term care partners, our assisted living partners, our congregate housing partners, because those are the settings that have the highest degree of risk and we believe have the greatest vulnerability. Those are also the partners that have the weakest supply chains compared to, for instance, our hospitals. Banner, TMC have very robust supply chains that they've really been maximizing to the greatest extent in order to protect their people and protect their patients. That becomes a little bit more challenging for our long-term care partners. I'm going to stop there, and I will take questions before turning it back to Bob. Any questions? Awesome. Well, I'll show you just one final sort of graphic representation. Dusty, do I have it, or do you? That's okay. And, okay. So this is another great map produced by our EPI and GIS teams, and again, you know, it looks like a bunch of dots. I realize that, but it really makes the point. You'll see some large multicolored dots here. It makes the point that really it's a relatively small number of facilities that are, or congregate settings. I probably shouldn't call them facilities because in some cases they are not licensed facilities per se. It's a relatively small number of congregate settings that are really overrepresented in terms of the number of cases and certainly in terms of the number of deaths and hospitalizations. With that, if there are no other questions, I'm going to turn it back to Bob.
Okay. Let me see if I can do this now.
Not as easy as it looks, right, Bob?
Okay. Can I blow that up any bigger or no? Okay. Okay. So, wanted to share this one with you. If you look at cases and deaths by day, you get wild variation between days. So it's much easier to look at 1 week at a time and much more representative of real world where we're at. So the bars here are cases by date of specimen collection, and the solid line graph here are deaths by date of death. Obviously, as with all epi curves, data will lag, so you will see in future weeks a significant increase to the height of the bar in week 18, and even some increase the height of the bar on week 17, same with the line. I think it is safe to say at this point we have passed a peak. I'm not going to say the peak, but a high point in our epi curve, realizing that any kind of modeling of what's going to happen in the future makes assumptions, and for this to continue to decline at a modest rate, not as sharp as it looks here, because again, these will increase in the coming weeks, but whatever modest decline we have, the continuation of that depends on the same factors being in place, the same level of social mitigation occurring over time. And that clearly is not what is taking place, especially with opening of restaurants starting on Monday and the potential for the removal of the stay-at-home order when it expires in the middle of May. Those criteria will be different. So when you think about going forward, we have been monitoring EM resource on a daily basis to assure that hospital capacity remained intact, and of course it has very, very much so had additional capacity available to it. But as we change social mitigation in the future, if that results in an increase in transmission rate, which one would assume that it would, we're starting that increase from a much higher level than back in mid-March when we first began to do mitigation measures. So you should see an increase essentially with a running start, because we're at a higher point in terms of total numbers of cases right now. You also need to keep in mind that everything we see lags. So incubation period being about a week, probably needing a couple of generations of spread in order to see an increase occur, and then a couple of week lag time beyond that before testing is accomplished, results are in, investigations are done. For us to see the change that may occur because of changes in mitigation this coming week will be toward the end of the month, maybe early June, before you can actually say what's happening. Then if it is allowed to go, say, another week to build up a level of concern for a response, if mitigation were reimposed at that point, sometime in early to mid-June, it will take, just as it did in the first part of this epi curve, a few weeks for that to plateau off again and begin to come back down. But presumably, we will be at a higher plateau than we were the first time through, because we're starting from a higher jumping off point. That all assumes that the virus behaves the same as it is now. There is always the possibility, and it's a reasonably good possibility, there's some evidence that this is occurring to some extent, that this virus begins to behave seasonally. And as other seasonal viruses do, decreases its rate of transmission through the summer months. So that's sort of what we're hanging on to right now, prayerfully, as what may bail us out and prevent us from winding up at a significantly higher rate of infection when we plateau off again. Let me just, can I move on to testing capacity at this point, or should I open it up for any comments, questions first? Comments, questions on our epi curve?
There was one comment from Clint.
Can you unmute Clint? Dr. Kuntz?
Yeah, so this is Dr. Kuntz. Dr. England, shouldn't we be expecting to see a pretty good rise in cases purely for the increase in testing that we're doing, especially over the last week plus?
Dr. Coots, absolutely. That is true. Testing has not stayed level through all of this. And the next thing on the agenda actually was testing capacity, so this is a perfect segue. Testing, the availability of test kits to providers has obviously improved. Hospitals especially seem to have what they need at this point. Some of our outpatient facilities are still not there. The last we talked to some of the outpatient clinics, there was a really surprisingly small number of swabs on hand at that point in time for some of them. We just have enough test kits now where we're trying to push them out to long-term care facilities to do routine testing. Obviously, as that kind of testing capacity ramps up, the number of tests ordered will as well, and you'd expect an increase in the number of cases. We have to try and take that into account as we go forward. It's not going to be an easy thing, actually, to take into account.
And the commentary I will add to that is that, to me, the important piece isn't the total number of cases, but rather the total number of hospitalizations and deaths. Because we know that there are a lot of folks, well, what we know from Santa Clara County, what we know from Los Angeles, what we know from New York City, is that the background rate of infection, of unrecognized infection, is probably very high, in the 20 to 30%. And so we know that any blitz testing effort will uncover some of these relatively either minimally symptomatic or almost asymptomatic cases. I think what we need to have our eye on is hospitalizations, people who are requiring hospital support, and deaths. And deaths are a lagging indicator by about a week to 2 weeks, so we should keep our eyes really peeled for that.
I would add that right from the beginning, testing was so difficult that we ballpark guessed we might have 50 actual infections for every reported case, based on just what early indications we had about the relative number of very mild and asymptomatic infections. In fact, a couple of seroprevalence studies out of California did put it in that ballpark range, with a lot of caveats and a lot of issues, legitimate issues with the study design itself and what those seroprevalence results mean. At least I think we're in that sort of ballpark range. That would put us at about a 5% seroprevalence rate in the real world here at this point in time. And as more and more antibody testing rolls out, again, with wide variability on the quality of the antibody tests available, we will learn something more about that as we go forward. There's always, right from the beginning also, there was a lot of discussion about just letting this thing to some extent burn through, because you have to have herd immunity for you to have a natural epidemic peak and a resolution of the outbreak curve. With something that is as infectious as this turned out, the estimates I've seen vary from 50 to 70% and higher infection rate in order to build natural herd immunity. That At first, that seemed plausible based on the relatively low mortality rate if you included all of that asymptomatic infection, but it's clear to me now that as a society, we would never tolerate allowing a natural outbreak curve just to resolve this on its own like that. So we're in this mode of slowing the spread, preserving the capacity of the healthcare system, and obviously buying time for research to hopefully bail us all out at the end. As testing capacity increases, I really, really want to keep the emphasis on the places that need it most. And to me, it's not a waste of testing, especially given what we continue to learn about in prolonged shedding and asymptomatic infection among older adults and immunocompromised folks. It makes good sense to continue for us to push as many tests as we can toward long-term care and other congregate living spaces. Okay, having said that, shall we move to criteria?
Yes. Before we move to talking about the criteria for testing, any other comments or questions from the folks here or the folks online? Okay, I'm going to move forward to the next agenda item.
Okay, all right.
Do I have the,
I've got it up
got it.
on mine, but you can take the lead if you want.
Sure, I'd like to. So when the White House Coronavirus Task Force issued its plan for reopening America, one of the things that became really evident to us almost immediately was that there was a need to come up with specifics that were locally relevant to Pima County, and that if our community was going to have any level of trust in terms of any phased reopening, that these criteria needed to be relevant to what our situation on the ground, and needed to be understandable by a lot of folks. And so what we did is we took that document and really try to break it out into things that you could measure and that we had the capacity to talk about here in Pima County. And we came up with we grouped them into 3 different categories. First were issues that had to do with the dynamics of disease and this infection in particular. But these 3 items are actually part of that White House coronavirus plan. That is decreasing the number of decreasing positive cases over 14 days, decreasing COVID-19 related deaths over 14 days, and decreasing symptomatic cases over 14 days. And those were the COVID-like illness reporting out of the BioSense surveillance data. There were also clear to us that there were items that had to do really with the capacity of the healthcare system in order to confront this. And so one of the things that was articulated as an aspirational goal is that you would have adequate testing when everybody who's symptomatic had the ability to access testing. Remember that fairly early on, we were actually, and to a certain extent, continued to discourage folks who are minimally symptomatic. We continued to and certainly early on, we were actively discouraging those folks, in part to preserve resources and in part to preserve PPE. Both testing and PPE resources are so scarce. And so that was one of the items that one of the criteria that needed to be met. The other issue had to do with staffing and bed capacity. And this has been something that we've been tracking since the onset. And overall for Arizona, but but in particular for Pima County, our hospital partners have really stepped up to the plate and have been able to really demonstrate a strong amount of surge capacity in their systems to be able to deal with an increased number of cases. And then the third item has to do with the sufficiency of personal protective equipment. And that, I believe, remains an area that we are very concerned about. And although our hospital partners and to a lesser care, our ambulatory care partners have done pretty well in that arena. We know that our first responders, our EMS and police and fire, are still very challenged. And certainly
And
when
long-term care as well.
well, I was going to say, and certainly when we add long-term care facilities and other essential workers, people who are delivering stuff to our homes, people who are stocking shelves, and then we are severely undersupplied. In the hearings that we've had with regards to restaurants, pools, gyms, resorts, and tourism, this has been a recurring theme. How do we get our hands on PPE in order to mitigate risk? Additionally, there were what I call public health criteria. And that had to do with the ability to do timely contact tracing and testing of symptomatic contacts, and being able to support those folks who were testing positive, who either required isolation or quarantine, but who could not be discharged to home either because they were homeless or because they had a home situation that was not conducive to their adherence. So these are much tougher metrics to meet. When a person gets a test, I know that this group knows this well, but when a person gets a test, that result, when it's reported out, is reported back to that provider, who then reaches out to that patient. Electronically, it is transmitted back to the state if it's a reportable disease, and the state then transmits that information to us here locally. The lag time between doing a specimen collection and the health department receiving actionable information is typically easily between 2 and 12 days, and that is the reality that we're dealing with in terms of these labs and how they report things. Once it is in the hands of the health department, Bob's team actually takes action very quickly to start that contact tracing process, largely within 24 to within a day and a half.
Of the folks we are able to complete an investigation on, it's been 1.7 days. Understand that there are a number of individuals we never reach. They won't call us back, or they don't want to be interviewed. So not including those, our average has been 1.7.
Finally, so this is how these criteria were identified. The indicator, red, yellow, or green, having to do with the degree to which these are being met or not, was largely subjective and was something that we had to come up with. One of the tasks for this group in particular is really to say, yes, these are the right criteria, or, Bob, criteria X is missing, or criteria Y needs to be modified. And we are committed, we are pledged to making sure that we are using publicly available data resources so that people can validate our assessment. But I think that is one of the charges for this committee is to either concur or enhance the criteria that we have proposed. Bob, with that, I was going to turn it back to the committee to sort of make comments on this, because this is really kind of the substance of the charge.
Great.
Any comments from our participants?
Francisco, this is Terry. Were there other criteria that you considered and did not include here?
Terry, in developing this list, I went through the slides from the White House and pulled, I think, every one of them out that I thought had a measurable outcome. There were some non-specific things that that weren't concrete, but I believe I've pulled everything that was concrete and measurable out.
Great, thank you.
Yes. And we have a comment from Dr. Hakim.
Hi, this is Iman Hakim, Public Health U of A, and I have, if I understood you right, Francisco, it takes up to 12 days to the case to be reported back to the county health department?
It can.
Positive cases?
So, Iman, it can take up to, between 2 and 12 days, depending on the lab. So NorQuest and LabCorp have a very robust way of transmitting that information back to the state, and that seems to be working well. Some of the newer lab entities that are in the space, because of the increased demand for testing, may be having some challenges. In fact, we worry that some lab testing that is positive is not being reported at all, point of care testing specifically. So yes, that is one of the real logistical operational challenges that our health department faces.
So when the patients themselves get notified, right away, or also it takes that long for a lag time for the patient to know?
Go ahead, Bob.
That depends on the provider. A lab will give a result generally back to the healthcare provider. Often, most of the labs are coming in much quicker than that long lab time, because most of the major labs have this system automated. So the healthcare provider gets a report. Sometimes they will get a hold of that patient the very same day. The ADHS will get notification from the laboratory perhaps the following day, and they'll enter it into MedSys, and we'll get it the following day. So we not uncommonly contact an individual and have them frustrated that they've been waiting for a call for a couple of days and wondering where the heck we've been, even though we're notifying them the first day that we get the information.
Yeah, and my question is related to if we will reopen the city with timely of contact tracing, and if it lags for that long, it is a missed opportunity to actually do effective tracing by the time. So if there is any way to streamline the work, so at least you can isolate quickly if there is a positive case, that's kind of my only concern.
Iman, I'm having a hard time hearing the substance, but it sounded like you were asking about how might we streamline the process once the health department, what is it that we're doing to streamline the process once the health department gets that information? Is that correct?
Actually, even before that, how we can be more, if it takes longer, is there any other way that we can interact quickly for the patient for isolation of contact? Like if a business knows that if it takes a week, you miss the opportunity for infection.
It doesn't usually take a week. It's usually a couple of days for us to, a day or two for us to get the information following the individual having been notified. We're not going to be able to make, especially the point of care testing system, work optimally. That one really does concern me. But otherwise, for the most part, we can get the information within a couple of days. Now, that's still not great if you're talking about wanting household contacts to be self-quarantining at home if they've been going to work for the last couple of days. So yes, there are real issues there in terms of being able to do optimal contact tracing in an environment where you can't know immediately.
In terms of, and it's a great question, in terms of where how to improve that reporting capacity from the lab to the state. That really is a state function, and because these reports are mandated by the state, and that's why the state has created the system for reporting. And I don't think that we locally, as a health department, have anything that we can do to speed up the process. We are dependent on the labs, and we're dependent on the state.
So in addition, know that contact tracing as a useful tool it has minimal utility in a context where you don't know about most of the cases because of inadequate testing, and you have widespread infection. As I said, we think we've gotten probably around 5% of our total population infected by this point in time. The general messages and the general social mitigation is going to be much more effective in that context. We were gearing up for contact tracing to be the primary tool to allow reopening, assuming that we could have been further down that outbreak curve with a smaller number of ongoing infections, so that you could afford to put all your eggs in contact tracing and isolation and quarantine as a control tool. If our transmission rate begins to increase again from here, even with ample testing, it's going to be less useful than it could be.
Any other comments from the participants in terms of where we are and what we need to be doing with regards to these criteria? Terrific. Well, then what I'm going to do is provide each of the participants an opportunity to give us their perspective and to provide a brief statement. And I will start off with our co-chair, Dr. Nancy Johnson. El Rio has been a really important partner to the health department and to this community in so many ways. But Nancy, anything that you need to convey to us as advice as we continue to refine these criteria?
Yeah. Thank you, Francisco. Can you hear me?
Absolutely.
I'm trusting that Dusty unmuted me.
He did.
When I looked at your criteria, it really looks like what we're living in terms of the criteria that we're looking at every day. And I think that the criteria is spot on as far as where we're living. You know, we're starting, I was listening to some of the other comments, we're starting to get more test kits, we're starting to get rapid turnaround on the results. The HIE is sending us alerts, on-demand alerts now, so we're able to reach out and give advice and counsel to the positive results. We're still struggling a bit with all the help we're trying to provide around the shelters and the congregate living, just all sorts of related problems, not only to COVID, but just that whole systematic problem of shelter and vulnerability and other things related to that population. So, I mean, this handout I found on spot for us and appreciated, you know, the guidance around good preventive health practices to your earlier comments about contact tracing not being very valuable now and what we can expect in the weeks to come, which is pretty much what we've been dialoguing about here internally.
Thank you, Nancy.
Are there other things, Francisco, that you would want us to touch on from where we sit?
No, Nancy, I think this is an opportunity.
They're swabbing people right outside my office right now. I can see them. And they have enough PPE, and everybody appears to be following good practice. So.
Thank you, Nancy. I'm going to take comments from Dr. Abakasis, the Dean of the College of Medicine. Dr. Abakasis.
I don't have any specific comments. I really, really appreciate all the efforts from Pima County, and if there's anything that we can do to help, I know that we've been providing kits to the extent that we have them to provide, and I know that the antibody testing is going well, so just please let us know where we can be of help. I really appreciate all of your efforts.
Thank you, Dr. Abacasis. Dr. Hakim, any other comments for us?
Thank you very much.
Thank you. Dr. Kuntz, Marana Health Center has been an incredible partner also in this process. Any other words of wisdom for the committee?
Yeah, thank you, Dr. Garcia. The one metric I think we might be missing is possibly looking at hospitalizations related to COVID-19 as a decreasing measure. I think that might give us a better picture versus decreasing positive cases. What I'm worried about is with increased testing, I think positive cases will continue to stay flat, maybe even increase a little bit, but that shouldn't scare us much as long as hospitalizations related to COVID-19 or influenza-like symptoms, either one, are decreasing.
Great comment. We have noted that, and our team here has made that comment also. Dr. Leonard, Desert Sanita.
So, can you hear me?
Yes, Jonathan.
Okay. So just looking at it and the challenge that I appreciate all of the work that you guys have done, and I do see a lot of validity in the work. I think the uniqueness of our community is always a concern for me because of the way that the community seeks care. Our proximity into Maricopa County for hospitalization is I think a little bit challenging in how we track things moving forward. But I think more will come out as we continue to move forward with these processes.
And Ajo certainly is a unique community, and we know that the challenges and the resources there are a little bit strained. So thank you, Jonathan, for being on. Rose, Intermountain Center's behavioral health is really an important piece of this whole thing. Since the get-go, one of the things that makes me lose sleep is what are the long-term consequences of social isolation and social distancing for the overall health and well-being of our folks. Bob and I have worried both about our staff and our community, and that's part of the reason why we wanted behavioral health represented in this conversation. Any words of wisdom from you, Rose?
Thank you, Dr. Garcia. I really appreciate this information, and I think it's spot on. A couple comments that I'd like to make is around employer notification for individuals who are testing positive and that are in the workforce. I'm concerned that the time that employers are notified is probably a little longer than when actual individuals and/or the county or state is notified. And I'd like to figure out how we can better address that, maybe with business leaders and companies who are getting ready to open up. We really need to be cautious as to ensure that there is proper reporting going on. I mean, given the economy, given the fact that many individuals have been out of work, my hope is that we will not have anybody who will be reluctant to report to their employer because they would have to continue working and generating some type of income. Secondly, I think the whole issue around PPE, that's been a big concern for us. We certainly have had to go out and purchase PPE, and right now we're probably on a 3 to 4 week delay of receiving PPE. My concern is that potentially gets worse as we start opening up, or as businesses start opening up, because I would imagine that some of these businesses are going to also be looking for PPE. ideally, if there was some centralized function here in Pima County to help manage this. Otherwise, we're just bidding against each other, and it can be very costly, and/or it can be very costly for some of our smaller businesses who may not be able to provide that for their employees. And I think we have to really keep an eye on that supply chain and better understand what the inventory is for Pima County businesses. In regards to behavioral health, we certainly have seen an increase in individuals seeking services. Fortunately, we've not received too many crises as a result of the virus, but we as an organization have certainly been maintaining that contact. But we are seeing a number of individuals who are seeking services.
Thank you, Rose. Judy Rich, our TMC CEO, has been a tremendous partner to us, and anxious to hear, and part of the dialogue that we all have every Friday, strategically thinking through as a system some of these challenges. Judy, what are we missing from our phased criteria? Okay. Please.
The conversation.
Oh, there's Judy. Thank
Can you hear me now?
Perfect. Now I can hear you.
Okay. I think the criteria looks good, Francisco. I think the amazing thing about how the conversation has changed over the last 8 weeks or so is that it's all about the antibody test, and it's all about visitors for us. So there's going to have to be a lot of education for our community about how you can go to a restaurant and have dinner, but you can't come into the hospital and see somebody who's very, very ill. So there's a whole campaign that we're going to have to be a part of to try to explain this very complicated issue to the people who live here.
That messaging issue is going to be something that's going to be with us for a while, and is a challenge that I fear is going to be difficult to surmount. Thank you, Judy. James, are you on? Would you like to make a comment? Our friends at Arizona Complete Health and one of our large access providers here locally, do you have any wisdom to share with us?
Sure, thanks, Francisco. Can you hear me okay?
Absolutely.
Awesome, great. Just a couple of things. I totally agree with both Clint's and Rose's comments around, the understanding of, I see that we have the staffing in beds, which is fantastic, but, as the hospitalizations increase, one of the concerns we have really is around, the insurance, looking at also, and I don't know if we need to do this, but looking at, the number of individuals on ventilators, and are there, enough ventilators needed if that continues to rise with the hospitalizations, et cetera. From a PPE standpoint, also have the concern that totally agree and understand the need to start elective surgeries and those kinds of things, but then that will also be competing for the PPE needs, for the healthcare workers, as well as, individuals needing PPE to go in to get their haircut at salons and things like that. So do definitely have some concerns in the community around those pieces. And then just as we move forward, if there's anything that you would like me to represent as far as sort of Medicaid policy, things that are happening in the Medicaid world, et cetera, I think Access is doing a good job at keeping people informed through their frequently asked questions online. If individuals don't know, Health Current, the HIE, has set up a COVID web page that represents all the health plans. So instead of the 7 Medicaid plans trying to communicate individually with providers, there is a COVID web page on Health Current where all the plans are posting information, et cetera, to try to make the communication more streamlined and effective. But if there's anything that you would also like from the Medicaid side of it, reported numbers of individuals going on Medicaid, et cetera, I know it's not exactly related to this. I would be happy to provide that going forward.
Thank you, James. Chad Whelan is the senior executive for Banner Health and oversees our operations both at the South and Tucson campus. Chad, you've been at these conversations with us all along, been working really hard with one of our mobile testing sites up on North Hills. Anything else that you want to share with us with regards to the phase criteria or any other comments?
Yeah, so just a couple things. So the criteria is spot on with the one adjustment of the positive cases with the increased testing and thinking about hospitalizations and other measures of that. I think the idea that I have would be, rather than framing this as a reopening set of criteria, because administrative controls, I think, are being moved away faster than maybe we're all comfortable with the executive orders, is perhaps guidance for personal and engineering controls in this state of administrative controls moving away faster. Helping people understand what can I do, what can my business do, given that the executive orders are, they're here. It's opened.
Thank you, Chad. I'm going to turn it back to our chair and then subsequently to Mr. Huckleberry for some concluding remarks. Terry, do you want to say anything?
Yeah, I do. First off, I really want to thank everybody for their active participation. I'm new to the county, as many of you know, well, not new to the county, but new to this position. And I'm always amazed at the ongoing engagement, commitment, and foresight that community members, especially in this case, have been able to provide to the health department. Bob and I and Francisco and Mr. Huckleberry will take your comments and look at them and see how we can move forward. The one comment that I think is striking and probably is a thread through everything is our need for communication both to the healthcare sector but also to the community, to ensure that as we move forward, people feel that they can have trust in the decisions or the recommendations that we are providing within the context of the regulation of the state. So thank you for participating.
Mr. Huckleberry, any concluding remarks?
Just to thank everybody for participating. I know that your time is valuable, but your input here is also very valuable to us in helping us formulate how we move forward from here. Thank you.
And with that, I'm going to conclude our meeting. Again, we thank you for your fierce and continuous partnership. This is something that none of us would have planned for. Yes, Dusty, is there a comment? Will you open it up? So please go ahead.
Clear in that one thing I'm struck with in listening to particularly Judy, I'm wondering if one thing we might do is try to standardize our language around how we're communicating with our patients coming into our environment. If that's something we can do in the short run around healthcare, around visitors, particularly as we were looking at well-child visits yesterday and screening mammograms and things, and trying to craft language, I just think it might help the community understand if we can come up with same language. So that was just a thought earlier on that we can connect ourselves possibly and bring that back rather than giving mixed messages to community, as Terry was mentioning.
That's
in our community
great
Thanks.
Great point, Nancy. I think one of the things that community scratches their head is when they walk into different healthcare facilities and are at least perceiving different messages. And I think that common messaging is really important and goes back to the point that Terry made. So on behalf of ourselves here in the county administration, again, we thank you for your fierce and continuous partnership, and we will be in touch with you as we continue to try to operationalize some of the feedback and recommendations that you've made. Thanks a lot for your participation today.
Thanks for using WebEx.